Okay, good morning.
Good morning.
All right, I got to do the legal permission thing.
Mm-hmm.
The name of the law is called the Health Information Portability and Privacy Act, and it means that I can't talk to you in this group without breaking the law. So I need to get your permission, so could I have my permission to talk to you this morning?
Yes.
Thank you very much. Okay. All right, number one, how's the diabetes?
Well, the sugars are a little high, but you know what? I expected it.
Right. You know why they're high?
Well, my body's gone through so much.
It's a stress.
Yes.
In other words, a stress response. We often find even our non-diabetics have elevated sugars. And if you think of the pain is a stress response. It's part of the fight or flight response, and you're having that. And we expect, though, they're going to start coming down. So the highest one that you had, do you remember, was?
In the middle of the night was
Something.
350 maybe.
Good. And this
Something.
morning?
This morning was
Good.
250, and then the last one they took was 295.
Good. Okay, so we got to keep giving you some insulin while that comes down. And remember, we talked yesterday about what we would do today.
Right.
So let's remind me of the insulin dose you took pre-op.
40 and 20
In the morning.
in the morning, and 10 and 10. 10R, 10N.
Okay. And so what we remember for the past 12 or so hours, you've had a 295, a 250, and a 3-something. Okay. So what I would say to you is during the rest of the day, we're going to keep an eye on those sugars, and you'll get the little bit of regular. But this evening, if you were taking a usual night, you would usually take at night how much?
10. Bedtime, 10, and dinner time, 10R.
You would take 10 at dinner and 10 at bedtime.
10 NPH.
10 of NPH at bedtime.
They're two different kinds.
And that's not too far from where we may want to be. You know, we might want to do that tonight.
Okay, yeah, I understand.
Let's see what your sugars are, and maybe call me this evening, and we'll chat about it.
Yeah.
When you got ready for the day before surgery, you cut that in half. Is that correct?
No, I just did my nighttime one.
You
the
did your
daytime
nighttime?
was full.
But you did a regular nighttime, a usual nighttime.
But not the full dose, because I didn't want to go into low sugar and have
So
to eat.
the night before surgery, how much did you take?
I took 5 and 5. 5 dinner, 5
Gotcha.
bedtime.
And the next morning, what was your sugar? 185?
Yeah, something like that.
Well, we might do a 5 and 5 tonight. We'll see how your sugars are later today. You're still having some stress, which might go for the 10-10. On the other hand, if your sugars come down a little bit during the day, then we might want to cut back. So if your sugars during the rest of the day today are in the 200 to 300 range, then I'd probably do your 10-10 usual.
Yes.
And then we'll talk tomorrow morning.
Yeah.
And again, our negotiation is a little bit like the pilot and co-pilot bringing in a jet for a landing. And 250s and 295s and 350s, and those are fine. I just can't stand 40.
Right. No, the 350, I got a good headache. I know when my sugar goes over.
Right, and we can
certain
fiddle a
point.
little bit with that, but a headache, fine. Passing out, falling down the stairs,
Right,
at 40,
yes.
no, we can't do that.
Right.
So if it's slightly up during the next couple of days, that's fine, and we have to continuously negotiate. What we expect is your need for insulin is going to go down.
Right.
But I don't know, did you meet our nurse in pre-op who had the surgery with us who's a diabetic?
No.
Okay. She had surgery with us 2.5 months ago and was on 60 units of insulin a day. And it's now 2.5 months later and she's on 10 a day.
Oh, yeah.
So that's good, but it's not 0.
She's a type 1.
I don't
No, she's a type 2.
Oh, she's 2.
So we're going to, again, what our plan is, we are, just like the seriousness of landing a jet, we have to constantly talk, gently pull back on the rudder a little bit, you know, put the flaps down and bring it in slow and careful.
Right.
So we'll need a lot of sugars and a lot of talk between the two of us while we bring it in. But that's the plan. And again, just to re-emphasize, 250, fine. 50, not fine.
Right.
250, I'm okay with. 350, I'm okay with. 50, I can't stand.
Yeah.
Well,
No,
but 350, I know it's not
I
pleasant.
was not feeling good at 350.
But I can stand that. But if you feel a little puny as opposed to 50.
Right.
So,
Understandable.
all right. So that's our goal. Pain?
No, I mean, the only pain I think I have is the stab wounds.
Say again?
The stab wounds.
How much pain is that?
I haven't had pain medicine since yesterday.
I can't hear you. We want this to go out.
Not very much pain.
Huh? Pardon me?
Not very much pain at all. I mean, it's.
So you had major surgery yesterday,
Mm-hmm.
and not very much pain, and no pain medicine since yesterday?
I only, that first tube, I only did so much of it, and
Yeah.
that was it.
Yeah. You're welcome.
I mean, they told me, man, patients that come through there, they go through, suck the first one down and go half another.
Mm-hmm.
I didn't even hardly do half of one.
We like that. Good, good. Nausea?
A little bit, I think.
Yeah.
But then I
You know
think,
that we
is it
use
really
another
nausea?
term for nausea, and it's called upset stomach. It's
What's
hard
that?
to imagine a more upset stomach than one that's just been crushed and stapled and sewed on. So we don't get surprised if you have a little bit of nausea.
I mean, it comes and goes so quickly, I get confused whether it really is nausea.
But that's okay. We're cool with that. That's
Yeah.
fine. You
Yeah.
don't, that's no problem. As long as it's mild or short or occasional, we're okay with that.
Yeah, no, I'm feeling good.
Good. And how about tolerating liquids?
Oh, yeah.
Good. And saltine cracker?
Well, you know,
Not much. Good. Normally during the day, would you be hungry?
no, I'm not a hungry person.
You don't get hungry?
Not really, no.
All right. Okay. Walking?
Yep,
Good. How do you feel when you stand up?
just fine. No lightheadedness.
They check your blood pressure and all,
Yep,
and that's okay.
they tell me it is.
Good. And you feel okay.
I feel good.
Good. The wounds are healing, the bandages are all
Well, they're starting to itch.
good. Peel that tape off. If you do peel the tape off a cut, guess what could happen? You could have bloody fluid. So don't wear your best white silk blouse, an old oversized sweatshirt from Walmart, dark color, something like that, and either throw it away or wash it. But get the tape off early, because the tape can, that itching is kind of pulling, it can cause a lot of scar tissue and blistering. So
So as soon as we can, take it off.
I would, that's what it says in the manual, and I agree with
Yeah.
that.
I just didn't know if we should wait for you.
Well, there's no rush. I mean, a couple of hours, but
Yeah.
we have some people come back on Tuesday next week and their bandages are still
Oh,
there.
no,
We don't want to do
I
that.
couldn't have tolerated that.
Questions? Any other things? I'm kind of,
Oh, curiosity, it's related to the other question I had the other day. How many feet did
Did I?
we bypass with?
let me look, see if I remember. Okay. Yeah, 185 yesterday. Six feet.
Okay. And then he said, you mentioned something about the liver.
You've got some liver disease. I mean,
Now,
if you take a diabetic and look at their liver, if you take a diabetic who's been diabetic for a while and look at their liver, if you take an obese diabetic,
yeah,
ever taken any Tylenol?
yeah, I have, but
Don't
not.
take any more.
Okay. So what do I do then for headaches and all that kind of stuff?
You have no answer for that. What would be great is if this surgery was perfect.
So this surgery should help this condition.
Okay, well, you're changing questions on me, so
Yeah, I
let's
know.
be careful. Let's finish
Yeah.
one question before we go to the
Right,
next
right.
one. But one question is, what about pain relievers? And the answer is, we do a lot of good things with this surgery. We hope to help with your diabetes, high blood pressure, high cholesterol, da. But we take away your chance of walking to the grocery store and finding a whole row, a whole shelf full of pain medicine that you could take. All of that's now out. And all of it's especially out in you because Tylenol is like definitely out. See, now when you talk to somebody, you ever notice like this? Tylenol's definitely out for you and your liver. Never. Never again. Never. Don't
So
ever.
this should
And
not be
ibuprofen
passed.
also bothers the liver. And it also means all kinds of wacky drugs like Vicodin and Percocet and Lortabs, which are combinations of narcotics plus Tylenol, never Do you know what I'm trying to say?
Yeah, never.
Right.
So I
'Cause
should pass it
you're-
on to my primary care physician.
Yeah, you
Yes.
have a liver which looks beat up.
Mm-hmm.
Now, a lot of ways a liver can get beat up, just diabetes,
Mm-hmm.
just obesity. So we have some people who are just obese and some people are just diabetic, and their liver can get beat up. But we also know that there is something in the environment which we can help with, and that is no Tylenol, no alcohol.
Oh, I've never drank in my life.
I didn't have to worry about
No.
that, but those are both what we call, the big word for that is hepatotoxic, or they hurt the liver. And we know your liver's hurt, and now we're going to stop that question and move to your other question, which is the surgery going to make your liver better? And the answer is yeah.
Okay, good.
But there's a trick to that too.
Yes, there always is.
Yeah, there's a hook.
Yep.
And the hook to that is that when we burn the fat out of the liver, which we do, okay, that's what the surgery does, it burns the fat out of the liver, it stresses the liver. So if you were to measure liver function tests in our patients over the coming years, they're slightly elevated. The liver is kind of bruised by this burning of the fat out of the liver. So it's a tremendous warning, don't hurt it anymore.
Right.
Because you came to me with some baggage of a slightly bruised liver. Now, we've seen worse.
Yeah. No, I
But with
understand.
your diabetes and with your obesity and with the surgery, we're going to make it better. We're going to make it better. But while it's being made better, it's like going to the gym lifting weights. If you give yourself too much to lift, you can tear a muscle.
Yeah.
In the same way, the liver can be stressed beyond its ability to recover. So no Tylenol.
Right.
Do you think you should take cold medicine?
I rarely do, but.
I know, but
it's
do you
got
think you're
Tylenol
allowed
in
to?
it. No.
Why? Because there
Okay.
might be Tylenol. in it.
Yes. Most
Okay.
of it has Tylenol.
Anything, everywhere you look, you need to
Has
be looking out for Tylenol. That it might be sneaking into a drug for your back spasm,
That's called the
acetaminophen. But you need to be very knowledgeable that you never get anything like Tylenol in you ever again.
But you're, like the Motrins.
Motrin is a good
Hurts.
question, but Motrin is a double drug.
Yes.
It's a double drug. It damages the liver and causes ulcers.
Okay, so that-
So any drug you don't want to take right after Tylenol, it's not Motrin.
Right.
How about naproxen?
Never heard of it.
It's naproxen.
Never heard of it.
Aleve. How about
Oh.
Aleve? No.
No,
Why?
because of the
Ulcers.
ingredients.
Because of the ulcers, right, exactly.
Mm-hmm.
How about aspirin?
No,
No.
ulcers.
Right.
No.
Ibuprofen.
No, not ulcers.
That's Motrin, and that's liver and ulcers.
Yeah.
How about Benadryl?
Yeah, now what about Benadryl? What about drug X? In other words, when you leave here, one option is you could call me about every drug in your
Right.
life forever. The problem is, I don't know that much. I mean, I know a lot about my one little tiny area. I might be the smartest mini gastric bypass doctor in the world. Okay,
Probably
great. That's all right. But that's my one little area. But there's zillions of drugs. So, like, think of drugs like methotrexate. What about that? I don't know. For the future, you could always call me like we're doing now, because you could ask me about Tylenol. No,
No.
because I know Tylenol.
Yeah.
Okay, ask me about methotrexate.
You don't know.
I don't know. So you're always welcome to call me, and I like it if you call me. But if you call me and ask me about methotrexate, you know what I'll say?
You're gonna say, I
I'll
don't
say,
know.
I don't know. So what do I recommend for you? Not just for you.
Research it.
We do the three things. Number one, if some doctor is giving you something, a prescription, the first thing you should reflect back to them is, do you know what the side effects are of this? You know, I know I'm taking it for my eczema, psoriasis, brain tumor, urinary incontinence, sprained ankle, whatever. But, and I appreciate that you want to help me with that, doctor, because that's why I came, but tell me what the side effects of this are. Like, ask me about the side effects of the mini gastric bypass.
Good.
I know that. I know that.
Yeah.
I know that, right? But I don't know methotrexate. First, ask your doctor who's given it to you, and he or she uses it, so they should know it. Two, step number two. Ask your pharmacist, right? Say to the pharmacist, hey, my doctor gave me this. He said it's probably okay. Any side effects? And you might say, oh, there's 1,000 side effects. Say, well, I'm particularly worried about my liver and ulcers, because I have a mini gastric bypass. But I want to know about all of them, because if your bone marrow dies or anything at all, please tell me. I'd like to know. So number 2, step 2 is ask your pharmacist. And then step 3, the internet.
Yeah.
Don't leave out the internet, okay? There's all kinds of resources. You type in methotrexate under Google, and you spend the day reading all kinds of wacky stuff. The first 10 will be how to buy it cheaper in Canada. So, but, and maybe that's a good idea. But,
Because prior to this surgery,
yeah,
for the last 5 years, I've taken a lot of Benadryl.
yeah.
Because I can't breathe through my nose if I don't.
You know, we might help with that. How could we help with your nose?
I'll lose weight.
Yeah, but how would that help your nose?
Because I went through this with my ear, nose, and throat inspection. The weight isn't going to clog up the nose. I mean, it was treated for...
Well, let's talk about Benadryl and Sudafed. They're both drugs that sometimes people take for a stuffy nose, right? And the idea there is that the lining, the mucosa inside your nose, is kind of swollen.
Yeah.
It's puffy. Swollen and puffy, filled with what?
Mucus.
Water.
Water, yeah.
Okay, now, here's something funny. Do you remember we talked about weight loss after the surgery? Do you remember the numbers? Let's do that again. Of all the 3,700 patients I've operated on, the average weight on the day of surgery is right at 300 pounds. So some are 250, some are 350, but the average weight on the day of surgery, 300 pounds. The average weight loss at the end of 1 month for the average person, a 300-pound person, at the end of 1 month is 30 pounds. 30 pounds of what?
Water.
Water. Not fat, which we wish.
Water.
Water. And then towards the end of the month, we start burning a little muscle, right? But 30 pounds of water. Now let's go back to our patient, that is you. Let's take 30 pounds of water out of your ankles.
Yeah.
All of a sudden, swelling in your ankles goes down. We're happy about that. 30 pounds of water out of your bloodstream. Blood pressure goes down. That's why you have to keep up on the salt, right? Take 30 pounds of water out of your lungs. Breathe a little bit more easily, right? That's great. Your heart pumps better. Now also take 30 pounds of water out of your sinuses.
Yeah.
It's like Benadryl from heck.
Yeah.
It's the most powerful Benadryl you've ever taken. You've never taken Benadryl that got rid of 30 pounds of water.
No.
Also, how about headaches?
Never taken it for headaches,
But you know, we are a treatment for headaches. So we have lots of our pre-op patients. We have a lot of our pre-op patients who have headaches. And a lot of times they get better. That's not 100% because there are other things. But many obese patients have a swollen head. That is, their head is puffy. It's full of extra water.
Yes.
If you stick a needle into their spinal column and measure the intracranial pressure, it's elevated. And we're going to take 30 pounds of water out of your skull. Imagine that this is under pressure like your tire on your car, and we're going to go psss.
Yeah.
Ooh, I feel better. Okay? So even though I'm going to take away all your drugs, I'm going to take away the pain medicine you used to take for your knees. I'm going to take away the pain medicine you took for your back. Take away the pain medicine you took for your sinus headache. A lot of times my patients tell me when they compare their life pre-op and post-op. Pre-op, they had access to all the drugs in the world, including toxic things like Tylenol, which may have been unrecognized by you, may have been damaging your liver. But take your life pre-op and think of your aches and pains when you had the whole drugstore at your disposal. And now I ask my patients about your arthritis and headaches after surgery when I come to your home and steal everything out of your medicine cabinet and take them all away. Every person I've ever asked says their life is better after the surgery. That's different from perfect. You may still have headaches and aches and pains, but when you compare it overall to pre-op, and so then patients say, look, I am much better, but I want to be perfect. I want to have some more pain medicine because I feel better, but I still have, my knee hurts. And that's where we say, well, perfect is the enemy of good. By trying to get to perfect, you may get an ulcer or damage your liver. So think twice before you make that decision. Doesn't mean it's a wrong decision, but remember, this surgery has risks. And the number one risk is
Ulcers. So, okay.
other questions?
Told
We got a
you
lot of-
should've wrote it down.
Well, you remember you're going to call every day.
Yeah.
So if you have questions, read your manual. I think you'll
So
find.
do you send a report to my primary care physician?
Mhm.
You do?
Yep.
Okay,
Yep.
so
But-
all those words will be in there too?
Well, all those words are in the manual.
Right,
what I
I
would
gave
do-
her a manual.
Yeah, and what happens is if you take all the words that I really want to say to them, it ends up being what's called a
Right.
manual.
Mhm.
And the manual's pretty dense and pretty big, so sometimes it's hard for anybody to sit down and read that whole thing.
It is,
So I don't have like a condensed version of the manual.
yeah. No,
But the manual is really got, everything I just said is in the manual.
Mhm.
I had a
But she'll
question.
have the knowledge of the liver.
Well, I think the thing to do is to have her, if she has any questions, call me.
Mhm.
We find a lot of people are confused by some of these things, but there's a whole section where I'd say everything I just said is about the liver is in the manual. Why not take the Tylenol? Why not take the alcohol? That we see liver disease in people who are obese and with diabetes, and
She probably knows that, but
she may, but
we
if
didn't
not,
discuss this because I wasn't aware of this.
I have a question, Elite drops. Elite drops, a little bottle of Elite.
Electrolyte drops.
Is that a good idea? Is that something?
what's in it?
Seawater and what was that other ingredient? Chloride?
I don't know all the ingredients.
Sodium salt.
Yeah, okay.
Well, how much does Elite Drops cost? Do you know?
Oh, yeah, just $4 for a little bottle.
Well, I would say, I don't know what's in it, so you have to look on there and learn, and if it has salt in it, then there's nothing wrong with that. If you-
Seawater is the first ingredient.
Yeah, seawater is salt water, so that's,
I don't know how much salt that would be.
yeah.
A lot of people too want to take smart water instead, and so smart water is a good thing, but it doesn't have sodium. Has electrolytes but no sodium.
125 milligrams of sodium.
In
per
smart
serving.
water?
No, in the
No,
elite drops.
the elite drops. That's what
In the 8-ounce serving?
I,
In the
Well,
16
in
drop.
that,
the-
that's probably per serving.
per serving,
125
I'm sure
mg.
is what they listed as.
There's like 16 drops per 8 ounces.
$4, is that what you're saying, or?
Yeah, look at that little can of
Well,
tomatoes
no,
that
it's
are
not for
Stevie.
serving.
How much is in your can of V8 there?
Like 300 and something?
420.
420.
And how much do you think a can of that is? 25 cents or?
I don't know.
Yeah. Whatever you want, if you want to take, and anything you want to take like that, look into it first and find out what's in it. If it's just salt, I mean, there's nothing wrong with salt.
Is there a magic number of milligrams of sodium a day?
That's a great question. I'm going to restate it because that's a really good question. Is there an absolute amount of salt that you could calculate up and say, I need X number of milligrams per day? Okay. Or you could ask it a different way. You could say, is there a certain number of ounces of Gatorade I should drink every day? And the answer is, how much gasoline does it take to run your car?
Right.
Remember that?
Depending on your activity level.
Yes.
If you live in southern Nevada and you're going to be outdoors today, right, and it's 100 degrees, how much salt and water do you need as compared to what if you live in Toronto and you're not going out and you're not doing anything and your job is your 911 dispatcher? Okay, I have one of my patients who breaks the lug nuts on the bolts of road grading trucks and tractors outdoors in Henderson, here. Okay, he can drink 4 or 5 big bottles of Gatorade a day, and sometimes that's not enough. And I have other people. I have another lady who's a 911 dispatcher, and she doesn't get up and doesn't move. So there's no way to tell you how much, because each of you, number one, is different, and your days are different. But you don't need to know how much. And if I gave you even a hint of how much, it would be misleading. Instead, what I want you to do is stand up. And if you stand up and you feel weak and dizzy, it means you're not paying attention and you're not getting enough salt in. If you stand up and say, let's go shopping,
Wait a minute, I almost like the dizzy rather than go shopping.
That's an expensive business, my man. See, some people think, oh, save money on the food. Nah, you're gonna lose money overall with clothes.
So now there's kind
You'd
of,
be happy and healthy.
yeah. Is this, the darkness of the urine, that's another one that people use for hydration?
You can look at that too. So you want to drink enough so that your urine is clear, but we have other stuff going on for the urine. We're metabolizing and burning muscle, and so the best thing is, I mean, you can make it more complex if you wish, but I think I said something really clear and simple, which is just stand up and see how you feel.
Yeah.
Now you can do more complicated things, like you get a blood pressure cuff, and you could measure your blood pressure sitting and count the pulse rate and then stand up and see if the blood pressure dropped and your pulse rate went up. And there's a lot of complexities that you can add to this. Like you said, looking at urine, you could actually go to the store and you can measure urine-specific gravity and real complex things. But it's very easy, and that is eat a lot of salt, stand up. If you feel good, you've eaten enough. If you stand up and you are weak and dizzy, or you're tired, or you can't get up and walk around, it means you're not taking in enough salt.
Fair enough.
Yeah.
But one more question.
Mm-hmm.
In the coming days, you know, heaven forbid that something should be turned worse, and you're in your motel room or somewhere and these symptoms come up that are alarming, do we just go to the nearest hospital?
No, call him.
Yeah, you have a variety of choices. Let's suppose that her heart stops and she falls on the floor.
911.
Okay, then probably you don't want to be calling Sandy, right?
Right.
Sandy, you know.
Sandy, how do I call 911?
Yeah, Sandy. Yeah, what is the telephone number for 911?
Right.
Yeah, so if there's an emergency, then you call the ambulance and get in a local hospital. If it's a question, then you call us, and we can talk to you. Now, how many 911 emergencies have we had in 9 years? How many 911? Now you can remember, you and I, we're old enough. How old are you?
39.
Yeah, so you're not. We're old enough to have a heart attack right now, so we could have a 911 emergency. So it's possible, but we have not had any ever 911 emergency for any of our patients. Now we've had an occasional patient who, for interest, took a ambulance to get back to the hospital, but never a heart attack, a stroke, massive bleeding, you know, something like that that required minutes for treatment. But if that something could happen, now that could happen. I mean, with your diabetes and type 1, that's serious business. It could happen. If an emergency happens, then dial 911, get in the ambulance, and go with them, and you can call me. Now, I have gotten people call me, like one wife of one of my patients called me, and you could actually hear the ambulance in the background. She was in the chase vehicle behind the ambulance driving to the hospital. And she said, "Hello, this is I'm one of your patients. My husband, he's I'm going, what? Who is this? You know?" And it turns out that the family was at Disney World, and had spent the whole day. He was about 6 or 8 months after surgery, and he passed out on the ground, and he was holding his chest, screaming in pain, and he's having a heart attack. And I said, "Well, I don't think he's having a heart attack. My patients don't get heart attacks." "Oh, Dr. Rose," you know. I said, "Tell me what you were doing." "Well, we've been at Disney World all day, and how's he been doing since the surgery?" "Oh, perfect, and everything's great, and his blood pressure's fine." And I said, "Well, what were you doing right before that?" "Well, we just stopped to have something to eat." And I said, "What was he eating?" He said, "He was eating a hot dog." I said, so what we found is that he had swallowed it without chewing a big piece of hot dog, and it was really hurting. And but yeah, and he felt like he needed to go, so if an emergency happens, you're more than welcome to call me, but first call 911.
I have a lot of questions.
Maybe this is a stupid question, but my dad had a stroke, and one of the first things they gave him when they showed up was it aspirin, baby aspirin?
Yeah.
And so my question is if, you know, sometime
This happens in her.
way in the future,
Yeah.
you know, when that time comes around, when those things can happen,
What do you do about
deal with
that?
it afterwards.
No, we can talk about it. It's real easy. I think I'll give you some easy tips. Okay. The guidelines I'm giving you are for day to day. Let's suppose that we'll take your example and change it a little bit. That she gets kidnapped by terrorists and they're going to shoot her in the head unless she takes an aspirin tablet. take the aspirin tablet. In other words, there's some risk in the aspirin tablet, but you can see the risk of getting shot by the Al-Qaeda guy is much higher, so you take the aspirin tablet, and meanwhile you say, could I have some Tums with that, you know. So in your situation, if she were to face a stroke, and the reason they give you an aspirin is in the midst of a stroke, you're worried that the clot will damage brain tissue, and that the aspirin may keep some of that brain tissue alive, and so you take the aspirin. That's all fine. The bigger picture, though, if we step back for a second, is she's 1,000 times more likely to have had a stroke if she doesn't have the surgery. So her chance of stroke, now she has risk after my surgery. I might give her an ulcer, my surgery might give her an ulcer, but I'm taking away something in return. That you will probably never be in an ER with her worrying about that. That question you described that happened in your uncle?
My dad.
Your dad.
Yeah. But I'm
It's
just
not
saying-
for her. Yeah. Now, but if you say it differently and say generically, if you're in a life and death situation, and an emergency medical technician is standing over you saying, "You're going to die. You have to have a Tylenol tablet." You say, "Well, I'd rather die than have that Tylenol tablet." No, that's not what I'm saying.
Right.
What I'm saying is most people take Tylenol by the fistful because they have a hangnail.
Yeah.
And what we're saying is Tylenol is deadly to the liver, and a lot more deadly than we really realized in the past. So what we're telling you is don't take Tylenol. Now, if you're in an emergency situation, life and death hangs in the balance, you can take a Tylenol. You can take an aspirin.
Yes.
But in general, what we find is a lot of times you don't even an emergency situation. I had somebody call me from the hospital bed, and there was a nurse trying to give her a dose of Tylenol. And she says, "You know, I'm in the hospital, I've had a broken hip and heart attack," or it wasn't a heart attack, something, and they want to give me a Tylenol, and I won't let them, Dr. Rutledge. I just won't let them. So, excuse me. Hey, this is Dr. Rutledge. Hey. Uh-huh.
Car accident or something. People working on me need to know, you know, what not to give me or what to give me.
Is it
you know.
confidence?
But
Here are your
you
receipts.
take whatever they give you. It's still day-to-day living we're talking about.
Yeah, but
You know. And on top of that, their ability to treat me as an obese person is much harder than as somebody thin anyway.
Sure, yeah, that's very true.
So did that answer that question?
Yeah.
How's your voice?
Fine.
Sore throat?
A little. It's not bad though.
Too bad. You can still hit high C?
Well, I haven't tried yet, but
Okay.
I might later.
All right, okay. Good.
I don't have much support down here right now, so I probably wouldn't try.
No, okay. We bypassed 7 feet, an extra foot,
Yeah,
and so hopefully that'll be right for you. How's the pain?
it's not bad.
Okay. You should take an extra dose of the high, strong, powerful narcotic called Dilaudid when you get upstairs.
Okay.
That will probably make you sleepy for a while, and then we're thinking of your discharge being later this afternoon. The studies show that the narcotics, we're not going to give it to you forever, we're just going to give you that one big dose before you go home, will decrease the stress response of surgery. And so we prefer that as opposed to kind of toughing it out.
That'd be great.
Nausea?
None. Zero.
Pardon me?
Zero.
He looks over the
I'm
camera.
very pleased about that.
Good cut out of there.
Right. So that part we'll put on the web.
Yeah, that clips.
You're walking okay?
Yeah.
Good. Taking your liquids?
I feel like they sit right, I feel it burns right here.
Now,
but-
why do you think that is?
Because you stabbed me 5 times.
Crushed your stomach.
But
Stapled it.
how do you know it's in?
Yeah, I mean,
Yeah.
you know, I'm sure that'll go away with time.
In other words, that stomach in there is raw, and you're pouring, Gatorade and soup and crackers on it. Yeah, a little discomfort's not surprising at all the first
That's what I
day.
thought.
What's surprising is not worse. You
Yeah.
know, you'd think if you had a raw, stapled, stitched stomach, it would hurt more than this.
Right.
So some pain discomfort is okay.
It's tolerable.
Right, and the narcotics will help put that away. Your body is responding, alerting you to the fact that it has this terrible experience from yesterday. And we know it was terrible. We know you were hit by a bus yesterday. We don't need any more information about that. So let it go to sleep. Take the narcotics, a little bit of a nap, and you're going to really start to feel like your old self again later today and tomorrow.
I'm surprised I feel as well as I do right now.
Yeah, these girls are in the same room, and they're both very level temperament. I've never heard anybody snap yet.
Yeah.
Things are going pretty good.
Well, remember you have an 8. I emphasize the 20% who have trouble, but remember 80% of our patients do not need the estrogen patch and do get through it. Some people, this is just a purely wonderful experience where they, everything is good. On the other hand, we want you to be vigilant, because when they break and have these events, it can really be unpleasant for the family and for them. And I think we heard that the other day, of crying while you're watching the cat food commercials. So.
No cat commercials.
Yeah.
Yeah. Nothing other than those. I mean, I was up peeing all night long.
Yeah, what do you think that's from?
The bag.
IV.
If we give you that amount of fluid to a normal person, they don't pee like that.
Really?
That's the surgery already working.
Oh.
Oh, well, that's what I figured. but-
Really?
Yeah, it's the surgery has changed your hormones inside you as of yesterday, which again is amazing that it happens that quickly. That urine coming out, that's the 30 pounds starting off.
I'm happy with that.
Yeah,
Was my liver way fatty?
mild.
Mild fatty. That's a good thing, right?
It's a very good thing. You need your liver.
Mhm.
7 feet, because I have more weight to lose, possibly, you think?
Yeah. Also, we couldn't go 7 feet in her because we might stress her liver too much. So we're kind of, 6 feet is a good choice for you, I think. And also, we have to say that if we try and bypass more, we stress the liver more. And so in your situation with the diabetes underlying and all that, I think we got a good treatment, but we want to be cautious of overdoing it. And so with the seriousness of the liver disease, it means that we didn't have, I didn't even consider it, because we got to be gentle with you and your liver.
Yeah, that's fine, and she'd be happy with the, I'm sure with the 75% of average weight loss. Just
don't hurt.
Hey.
Remember, what is my first assignment from you? First, do no harm. Okay. And I think we talked about the analogy of William Tell. In other words, by trying to get too close to hitting that apple and making you each a size 2 for next year, we're likely to harm you, and we're not. That's not our business. Our business is, although we know, sadly, in a terrible kind of twist of things, sometimes I hurt people. My goal is to help, and it should, in theory, be 100% help. But we're not willing to hurt very many, so that's why in that William Tell analogy, we aim a little high.
I have a question that I thought of yesterday after listening to Felice and her situation getting to dire, where she waited and everything. What if it was becoming apparent that you are going to lose too much weight? What about instead of doing a full reversal, could you do a partial reversal?
Easy, yeah, but people don't come soon enough. They keep.
That's what I mean.
They kind of, until they're near the edge of the cliff. She was near death.
Yeah, that's what she said.
Yeah, and that was a foolish decision, but it's also a decision that's understandable, because people who are heavy tell me their lives are so terrible as an obese person and so wonderful as a thin person. When they get offered the opportunity to go back to be heavy, I've had many people look me straight in the eye and say, I'll die before I'm going back.
So if she hadn't waited so long, you might have been able to just do it 3 foot.
Sure,
back.
we could have easily said, it looks like you're getting a little thin, let's back up. But since we were at the edge of the cliff,
Right.
we were,
Yeah,
we were, dancing on the edge of the cliff with our toes. That's not the point to be fancy. What we want to do is grab a hold of her and run back away from the cliff, and that's what we did.
I was thinking about that too. I
Yeah.
remember that, the way you said that.
But then I went to that class for the lap band, and they talked to gastric bypass, and they asked, will you ever lose too much weight? And they said, never. Your body knows when to stop.
No.
Not with the mini, obviously, but with the
Dr.
gas.
disagrees.
Yeah.
Right. If you join, there's some internet mailing lists on Yahoo. One's called OSSG Gone Wrong, which is Obesity Surgery Support Group, and there's one called OSSG Revision. And so people sign on there all the time with having to undergo revisions for either excess weight loss or inadequate weight loss. And And they talk about friends of theirs that have died with excess weight loss, and they've had to have the intravenous catheters and things like that to feed them. And so sadly, every kind of weight loss surgery can have risks and benefits. And the nice thing about the band is very rarely does it make you too thin, because drink a milkshake, you know.
Yeah.
You can handle that. But the Roux-en-Y gastric bypass, if it overdoes it, it's challenging to undo it. And then if you take the patient who's kind of resistant to volunteering to get it undone, by the time you have to go back and you do a lot of surgery in a sick, malnourished patient, it's often not a good outcome.
No, and do they actually remove the stomach? That's what I kind of understood.
No, not in the Roux-en-Y.
They don't.
No. They just bypass it, but where they cut it is very high.
Right, I saw the
And so
pictures.
the surgery is up near what we in surgery call tiger country. In other words, there are parts of your body that are easy to operate on. And then there are other parts that are very difficult and very challenging. So you think about brain surgery, you know. You wouldn't want to make too many errors while you're doing brain surgery. You'd like it to be very meticulously done and very accurate. If you're, let's suppose you're taking up a little bit of extra skin on your rear end. Maybe you could see that those two wouldn't have to have the same level of accuracy. Operating near the esophagus, where the Roux-en-Y is really dangerous, difficult work, because the esophagus is a two-layer organ, and so it doesn't like for you to operate on it. The stomach is a big, thick old guy. It's used to eating beer and pizza and fried chicken and handling it all, and anybody can sew on the stomach pretty easily and safely, and that's why we choose to work where we do. But revising a Roux-en-Y, you're up near the esophagus, and the other couple of organs that are right near you are the spleen, the aorta, and the liver. And that's serious business to undo a Roux-en-Y. Many studies quote 10 times higher risk of death and complications with a revision of a Roux-en-Y. And so it's real serious stuff. On the other hand, we don't like people to have a mini gastric bypass revision, but it's no big deal. In other words, surgically, technically, we hate that somebody would not get exactly the weight loss they wanted. But if you don't like this, bring it back, we'll undo it. It's no big deal. We're surgically, technically, it's a 30 to 40 minute surgery, and we think about that as what we call your exit strategy. You know, if you don't like this, it's a lot like sitting in a theater, getting ready for the lights to go down, you see those red exit signs. You know, I've never been in a fire in a theater, but I'm happy those exit signs are there, and it's easy to use. And the exit strategy for the mini gastric bypass is superb. It's easy to get out of.
That's great. Fantastic.
Yeah, that's what we've been telling our friends that say, isn't that kind of dangerous?
That's the same thing we say.
Yeah. And they're partially right. You know, your surgery yesterday was very serious. And really, we should have started off this discussion with a celebration. You know, we should start off by saying, you know, thank you, God. I mean, it was life and death yesterday.
Yes.
And here we are chatting about, oh, you know, soup and pretty minor things. Should I take a Tylenol? And, you know, we kind of skipped over the fact that, you know, it is serious surgery, and thank God, you know, everything went smoothly. I mean, really, I didn't have much to say. You know, it was just no runs, no drips, no errors, nobody left on base. You know, everybody great. So,
No, absolutely.
It's amazing.
I think we're done.
Yep.
Congratulations.